Okay, so now we're going to look at the oral cavity, pharynx, and esophagus. The digestive system begins at the oral cavity or the mouth, where four different digestive processes occur. You're going to have ingestion, secretion, chemical, and mechanical digestion. So all four of these different processes will actually occur in the oral cavity. Although the oral cavity is technically part of the GI tract, it houses two accessory organs, the teeth and the tongue. In addition, three pairs of accessory organs, the salivary glands, which are located in and around the oral cavity. These structures will turn ingested food into moist chewed mass called a bolus. Posterior oral cavity, pharynx, and esophagus then deliver the bolus to the stomach by swallowing. The oral cavity is an area posterior to the teeth and bounded by the palate and tongue. Structural features of the cavity will include the lateral walls of the oral cavity, which are formed by cheeks composed largely of the buccinator muscles, as well as lined internally by stratified squamous non-keratinized epithelium. So if you note the epithelial lining there, it's stratified squamous. It's non-keratinized, but it is stratified squamous. This is a beefed up layer. And again, this is where food's coming in. It can be abrasive. You know, if it's hot, you're going to get damage to that epithelial lining. So you want to have a nice thick lining there. The cheeks will terminate anteriorly as lips, formed by the orbicularis oris muscle, covered with stratified squamous keratinized epithelium. The integument covers most of the lips, portions near the mouth, which contains less keratin than the surrounding skin. The mouth's inferior wall is composed of muscles of the tongue and muscles that attach to the hyoid bone. Posterior to the lips and the cheeks are the gums or gingiva, which is covered with stratified squamous non-keratinized epithelium as well, overlying connective tissue, and maxilla and the mandible are where the teeth are going to end up being housed. You have a narrow band of mucosa, referred to as the labia frenulum, which attaches to the internal surface of the upper and lower lips to the gums of on the midline. The vestibule, this is the narrow space between the teeth and the gums and the internal surface of the lips and the cheeks externally. The space posterior to the teeth and the gums is referred to as the oral cavity proper. Now your palate, this is the superior boundary of the mouth. It consists of two portions. The anterior 2/3 is the hard palate, and the posterior 1/3 is referred to as the soft palate. With the hard palate, stratified squamous epithelium and connective tissue, this is going to cover the palatine process of the maxilla bones and the palatine bones. The surface of the hard palate is slightly rough and assists in mechanical digestion. The soft palate is stratified squamous epithelium overlying skeletal muscle, and it is arch-shaped. This is extending inferiorly from the soft palate is a projection called the uvula. The soft palate uvula will move posteriorly to prevent food from entering into the nasal cavity during the process of swallowing. So this is going to help to prevent any food from going up into your nasal cavity or nose when you swallow, okay? Remember, the epiglottis is blocking the trachea, and essentially what you're blocking these two areas, the only way food can then move is down the esophagus. And here is just the structures of your oral cavity. Your teeth, these are the key organs of mechanical digestion. They are located in the bony sockets or alveoli within the mandible and maxilla. They are held in place by bands of connective tissue collectively referred to as the periodontal ligaments. With the assistance of the masseter and temporalis muscle, teeth will masticate or chew ingested food, grinding it into smaller pieces. This aids in digestion by increasing the overall surface area of food. And by increasing the overall surface area of food, that allows for the digestive enzymes to have access to it in order to break it down into smaller, usable nutrients. And that process is going to be chemical digestion when you're using these enzymatic reactions. In a human mouth, an adult mouth, there are 32 permanent teeth with 4 incisors, 2 canines, 4 premolars, 6 molars in both the mandible and the maxilla. Generally, by the age of 12, all deciduous teeth have fallen out. These are your baby teeth. And all but a third set of secondary molars have erupted. The third set of molars are referred to as your wisdom teeth, and they erupt sometimes later between the ages of 17 and 21. And here you can see the deciduous teeth on the left and the adult mouth on the right. Now your tongue, this is a skeletal muscle that is covered with a layer of stratified squamous epithelium. It's attached to the floor of the oral cavity by a thin band of linguinal frenulum. This prevents the tongue from moving too far posteriorly. The epithelium of the tongue is arranged into smaller projections called papillae. Then there are 4 kinds of papillae: filiform, pungiform, circumvallate, and foliate papillae. All papillae except the filiform contain epithelium with sensory receptors. And these sensory receptors are going to be your taste buds. And they detect various types of chemicals, so these are chemical receptors that are associated with different taste sensations. The filiform papillae play no role in taste. They are covered with stratified squamous keratinized epithelium. They make the surface of the tongue rough, and by making that surface rough, it does help in mechanical digestion. There are 2 groups of skeletal muscles that control the movement of the tongue. Your extrinsic muscles, which control the position of the tongue, involved during ingestion phase of digestion, and they move the tongue during chewing to help turn food into the bolus. The intrinsic muscles, these control the shape and the size of the tongue, push food against the hard palate during chewing, and assist in the mechanical digestion. They also push the bolus posteriorly during swallowing. Your salivary glands in the oral cavity, there are 3 pairs which are going to end up secreting saliva. This is a water-like fluid that contains enzymes, mucus, solutes, and like I said, it's primarily water. And the saliva will get secreted through a duct into the oral cavity. The parotid glands, these are large glands located over the masseter muscle just anterior to the ear. And they secrete saliva through the parotid duct, which opens into the oral cavity near the second molar. Smaller submandibular glands are located just medially to the inferior portion of the body. The mandible will then secrete saliva through the submandibular duct, which opens to the floor of the oral cavity. The sublingual glands, these are situated inferior to the tongue. They secrete saliva through several small sublingual ducts, and they empty into the oral cavity just under the tongue. And here you can see we have our parotid glands here. Here's a submandibular underneath the mandible, hence its name, sublingual underneath the tongue. The basic secretory cell of the salivary gland is the acinar cell. There are 2 main types of acinar cells in the salivary glands. You have serous cells. These secrete water-based fluid with enzymes and other solids. The secretions are involved in the digestive process, generally released just before or during eating. And you have the mucus cells, which secrete mucus, which are primarily involved in keeping the oral mucosa and the mucosa moist, and this is released continually. The 3 main types of salivary glands differ in the proportion of the mucus and the serous cells that they contain. The parotid glands only have serous cells. They secrete mainly water and enzymes. The submandibular glands have mostly serous cells and a smaller number of mucus cells. They secrete enzymes mixed with some mucus. The sublingual glands contain mostly mucus cells, and they secrete mainly mucus with a small amount of enzymes. So saliva is primarily water, electrolytes such as sodium, chloride, potassium, ions, and a variety of variable amounts of mucus, depending on the type of salivary gland. But it can also contain enzymes like salivary amylase. Salivary amylase is an enzyme that's going to break down carbohydrates into small polysaccharide units. And then lysozyme. Lysozyme catalyzes the perforation of bacterial plasma membranes. This allows bacterial killing substances in the saliva to enter and kill bacteria, and lysozyme is actually one of the antimicrobial proteins that is part of the innate immune system. Hopefully something you got right on your last test. Saliva performs several functions in the oral cavity: moistening, lubricating, and cleansing the oral mucosa. Lysosome and immunoglobulin A deter the growth of pathogenic bacteria in the oral cavity. Mechanical digestion achieved by moistening and helping to mix ingested food into a bolus so it can be swallowed. And then the chemical digestion by using salivary amylase to break down carbohydrates. Many food molecules will dissolve in water of saliva, and these molecules then stimulate taste receptors on the tongue. Now, the process of secretion of saliva is referred to as salivation. And secretion from the three pairs of salivary glands are primarily controlled by parasympathetic nervous system. Remember, if your sympathetic nervous system is kicking in, you have cotton mouth or dry mouth. The sensory stimuli, such as the smell or taste of food, communicates information to the salivary nucleus in the brainstem. Parasympathetic fibers from the brainstem exit via the facial nerve to innervate the submandibular and sublingual glands, and via the glossopharyngeal nerve to innervate the parotid glands. Neurons from these nerves release acetylcholine onto the acinar cells to trigger the acinar cells to secrete more saliva. Now, the sympathetic nervous system will also innervate salivary glands. One of the only instances in the body in which sympathetic and parasympathetic divisions will have similar effects on an organ. The sympathetic nerves will innervate salivary glands and their ducts, triggering increased saliva production and transport through those various ducts. The primary difference is that the sympathetic nerves stimulate most cells, whereas parasympathetic nerves will stimulate mostly serous cells. The pharynx, this is posterior to the nasal and oral cavities, and it consists of the nasopharynx, oropharynx, laryngopharynx. We talked about those various structures on the respiratory system, okay? One thing I want to mention is that the oropharynx does house two sets of tonsils, the palatine tonsils and the linguinal tonsils. And the tonsils perform defensive actions. These are bundles of essentially lymphoid tissue, and they house various white blood cells. Now, the primary function of the pharynx is propulsion in form of swallowing, during which the bolus passes through the pharynx and then it will pass into the esophagus. The pharynx is surrounded by three pairs of skeletal muscles, the upper, middle, and lower pharyngeal constrictor muscles. And the muscles contract sequentially during swallowing and propel the bolus inferiorly. Once you exit the pharynx, you'll then enter into the esophagus. Now, the esophagus is a muscular tube that is about 10 inches long. It's posterior to the trachea, and it transports bolus from the pharynx to the stomach. The esophageal mucosa is lined with stratified squamous non-keratinized epithelia. Which contains esophageal glands, as does the submucosa. This secretes mucus to lubricate the bolus as it passes through the esophagus. The muscular externa of the esophagus contains 2 layers of muscle. The superior third of the muscularis externa is going to be skeletal muscle. The middle third is when you see an actual transition from skeletal to smooth. And then at the other end of the spectrum here, the inferior third, this is going to essentially be smooth muscle. At the junction of the pharynx and the esophagus, the muscularis externa is modified into a sphincter, which is the upper esophageal sphincter. And this will actually control the passage of the bolus into the esophagus. The gastroesophageal sphincter at the esophagus' inferior end, also referred to as the lower esophageal sphincter, regulates the passage of the bolus into the stomach, and this prevents contents of the stomach from re-entering into the esophagus. You don't want backflow from the stomach back up the GI tract here. And here you can see the pharynx would be in this region right here, and this is the long tube of the esophagus. And again, the esophagus is really just a tube. The primary function of the esophagus is to propel a small amount of secretion of mostly mucus. During swallowing, the skeletal muscles and smooth muscles of the muscularis undergo peristalsis, which pushes the bolus inferiorly. Now let's talk about the process of swallowing or deglutition. This is a special type of propulsion. It pushes the bolus of the food from the oral cavity through the pharynx and esophagus to the stomach. Swallowing relies on the coordinated action of the upper alimentary canal and includes the soft palate, pharynx, and esophagus. Tongue also plays a role in this process. It is the only accessory organ to directly participate in motility. Now, swallowing is actually going to consist of 3 phases. Voluntary phase, where the tongue pushes the bolus posteriorly towards the oral pharynx. It is the only part of the stage, or only stage, that is actually under conscious control. The pharyngeal phase, this is when the bolus enters into the oral pharynx. The soft palate and the epiglottis skill off the nasopharynx and the larynx respectively. And this involves involuntary contractions of the skeletal muscle of the pharyngeal constrictor muscles, which is controlled by the swallowing reflex and initiated by the medulla. The reflex arc is initiated when the bolus contacts the sensory receptors of the oral pharynx and triggers the elevation of the uvula and the soft palates, which is going to prevent the bolus from entering into the nasopharynx. The reflex also triggers the elevation of the larynx while the bolus is pushes the epiglottis down. This, together with the elevation of the larynx, prevents aspiration where food can enter into the larynx, or worse yet, into the trachea. The third stage is the esophageal phase. This is peristaltic waves which will move the bolus down the esophagus to the stomach. It begins as the upper esophageal sphincter relaxes, and neurons in the enteric nervous system then stimulate the inner circular and outer longitudinal layers of the muscularis externa to undergo peristalsis and massage the bolus inferiorly towards the stomach. And here we can see the 3 phases. You have the voluntary phase. This is where you have conscious control and you're essentially moving the food into the oral pharynx. The pharyngeal phase, and then the esophageal phase. The control of swallowing is almost entirely neural. Voluntary phase is under control of the cerebral cortex. which is the somatic nervous system, and the remaining two phases are regulated by the medulla and the enteric nervous system. Autonomic nervous system does not directly control any phase of swallowing. It does influence the esophageal phase. The parasympathetic division will stimulate peristalsis, and the sympathetic division will inhibit peristalsis. The stomach, what's going to happen with the stomach is the esophagus will pierce through the diaphragm and then passes through the esophageal hiatus to empty into the J-shaped organ referred to as the stomach. The stomach sits primarily in the left upper quadrant, just inferior to the diaphragm. The convex left side is referred to as the greater curvature of the stomach, and the concave right side is the lesser curvature. The stomach's going to have 5 anatomical regions. The cardia, this is the region where the esophagus enters into the stomach and receives the bolus from the gastroesophageal sphincter when that relaxes. The fundus is the dome-shaped body of the stomach. The body is the largest portion, and the pyloric antrum is the inferior portion of the stomach. The 5th area is the pylorus. This is the terminal region of the stomach, which abuts the duodenum, which is the first part of the small intestines. The pylorus is going to contain what we refer to as the pyloric sphincter, which controls the flow of ingested food between the stomach and the small intestines. The interior of the stomach contains folds, referred to as root, which will allow the stomach to expand considerably. And here you can see the stomach nestled there, underneath the liver. The liver is actually going to be laying on top of the stomach right here in this area. And here you can see the liver, here's our diaphragm, and then here's the stomach right here. The stomach has the same 4 tissue layers as the rest of the GI tract. And remember, the stomach is part of the GI tract. It has the mucosa, submucosa, muscularis externa, and the serosa. The muscularis externa of the GI tract usually has 2 layers of smooth muscle, an inner circular layer and an outer longitudinal layer. In the stomach, however, there's a 3rd additional layer of smooth muscle in which the fibers are arranged obliquely. And this is referred to as the oblique layer of smooth muscle. And these 3 layers will allow the stomach to perform a churning motion that pummels food into a liquid when it starts to mix with gastric juice, which is primarily going to be consistent of hydrochloric acid. The mucosa of the stomach is heavily indented to form deep structures referred to as gastric pits. The columnar cells and the numerous goblet cells are within the gastric pits. These are going to secrete both thick mucus that lines and protects the stomach from its own secretions. This thick mucus is bicarbonate rich, and it really helps prevent the stomach from essentially eating its own walls. And then you have the gastric glands. These are at the base of the gastric pits, and multiple branched glands that contain both endocrine cells that secrete hormones into the bloodstream and exocrine cells that secrete a very acidic enzyme-containing fluid referred to as gastric juice into the lumen of the stomach. And here you can see these gastric pits on that mucosal surface there. And there are 4 main types of gastric glands that secrete different products. The first is the mucous neck cells. These cells are going to be located near the top or the neck of the gland, and they secrete acidic mucus, not alkaline like the surface epithelial cells. This prevents neutralization of acid that is produced by the parietal cells. Which brings us to the parietal cells. The parietal cells are responsible for the secretion of hydrochloric acid. This is responsible for the acidic pH of the gastric juice. And it's an important component of gastric juice just because gastric juice will activate pepsinogen, which will start the breakdown of proteins. It will destroy many disease-causing organisms. Realistically, a lot of things that you ingest will just die off because of the gastric secretions, the acidity of those gastric secretions. And it will also stimulate the parietal cell production of the chemical intrinsic factor. And this is required if you want to absorb any B12. Okay. The third area or third type of cells are the chief cells. These are going to secrete an inactive precursor enzyme referred to as pepsinogen. When pepsinogen encounters the acidic pH, the HCl, it becomes an active enzyme referred to as pepsin, and pepsin will break down proteins. Okay, so here you can see a picture of the one of the gastric pits, and you can see these various gastric cells that line this pit, essentially secreting various secretions, all of which become gastric juice. Now, the stomach performs three primary functions: secretion, propulsion, and digestion. The acid secretion from the stomach is going to include gastric glands in the stomach that secrete multiple exocrine products, including hydrochloric acid, which is released by the parietal cells. The acid secretion from the stomach, the hydrogen ions are secreted by ATP-consuming pump in the plasma membrane, which is referred to as the proton pump, will drive hydrogen ions out of the cell and into the lumen of the gland while taking potassium ions into the cytosol. A chloride ion follows the hydrogen ions via a passive diffusion through this membrane channel, and this will end up forming HCl. Acid secretion occurs in this manner continuously throughout the day between meals at a basal rate. So again, this is an ATP process where you end up having protons going out, potassium going in. This is referred to as the proton pump. You also have the shift of chloride ions being secreted. The H and the Cl will form hydrochloric acid. And in this picture here, you also have the chief cells, which are secreting pepsinogen, and the HCl will actually cleave pepsinogen from its inactive form into its active form, forming pepsin. Now, the functions of the stomach: during eating, gastric acid secretions change from a basal rate under the influence of the parasympathetic nervous system and multiple hormones. The secretion can be divided into three phases based on the primary source of regulation. And we have three phases that are going to occur in the stomach: cephalic, gastric phase, and intestinal phase. The initial cephalic phase is mediated by sight, smell, taste, or even the thought of food, under the direction of the central nervous system. It prepares the stomach to receive food by increasing the release of hydrogen ions into it. The stimuli will then trigger output from the vagus nerve, which is the main nerve of the parasympathetic nervous system, and that will result in four physiological effects. The first is the direct stimulation of hydrogen ion release. And essentially, the vagus nerve will release acetylcholine onto the parietal cells and directly stimulate them to release hydrogen ions. The second is the stimulation of gastrin secretion. This is a vagal nerve stimulation triggered by the release of the peptide that stimulates G cells to release the hormone gastrin. This will trigger hydrogen ion secretion as well. The third phase third secretion is the stimulation of histamine secretion. The vagus nerve will stimulate the specific type of enteroendocrine cell to release the hormone histamine. This will trigger hydrogen ion secretion as well. And then finally is the inhibition of somatostatin secretion. Somatostatin is produced by the type of enteroendocrine cells located in the antrum of the stomach, and it inhibits acid secretion, vagal nerve stimulation, which will inhibit somatostatin release and has the effect of increasing the hydrogen ion secretion. Okay, so during the cephalic phase, this is just a sight, smell of thoughts and foods. Vagus nerve stimulation, this leads to an increase in gastrin, increase in histamine, decrease in somatostatin, which are all going to lead to an increase in proton production and eventually the production of HCl within the stomach. The second phase is the gastric phase. This begins when food enters the stomach and continuously stimulation is provided during the continuation of stimulation provides during the cephalic phase. The two stimuli trigger acid secretion during the gastric phase. First, the presence of food in the stomach will distend the stomach walls. This will stimulate neurons of the enteric nervous system and sensory receptors involved with the vagus nerve reflexes. Both the vagus nerve and the enteric nervous system neurons will release acetylcholine, and this has the same four effects as in the cephalic phase. The net effect is to increase the acid secretion. The second stimulus is the presence of partially digested proteins in the gastric juice. This will stimulate the enteroendocrine cells to produce and release gastrin. In turn, this will stimulate acid secretion. The positive feedback loop progresses as follows. Acid activates pepsin, which catalyzes protein digestion. The digested proteins will then stimulate more gastrin to be released, and that triggers further acid secretion and more protein digestion. The positive feedback loop in the stomach does not continually or indefinitely, does not continue indefinitely. Once acid concentration reaches a certain level, the pH is that of about 2.0, the negative feedback mechanism is initiated. If you have extremely low pH, 0 or 1, these levels will trigger somatostatin release, which in turn is then going to decrease the amount of secretion or production of HCl. So during the gastric phase, food is entering into the stomach. You get those vagus nerve and enteric nervous system stimulation. This leads to an increase in gastrin, increase in histamine, decrease in somatostatin. You're producing lots of hydrogens to be released, and that will eventually form lots of chloride, and you end up with, starting the chemical digestion within that gastric phase there. Now, there is something referred to as GERD. Gastroesophageal sphincter normally remains closed, except during swallowing when the mechanism fails. Acid from the stomach can regurgitate into the esophagus. If this occurs chronically, it's referred to as gastroesophageal reflux disease, or GERD, which may lead to pain, difficulty swallowing, vocal cord damage, and respiratory problems, and even can lead to esophageal cancer. There are multiple factors that can contribute to the development of GERD. This includes increased acid secretion, obesity, caffeine consumption, a hiatal and hernia, as well as medications such as anti-inflammatory drugs. Another factor that can actually contribute to GERD is a bacterial infection referred to as Helicobacter pylori. This creates a state of chronic inflammation and stimulates acid production. One of the simplest treatments is dietary modifications, such as consuming less caffeine and alcohol. Most patients also require drug therapy, which will include things like Prilosec or some other proton inhibitor to reduce the acid production. Antacids are the most common drugs used for GERD. They contain alkaline substances that neutralize the acid in the stomach. Hydrogen blockers, these will block histamine receptors on the parietal cells, which lowers the release not only of histamine-mediated acid, but also that of gastrin and acetylcholine-mediated acid. And then finally, we have your proton pump inhibitors. These are powerful inhibitors of the proton pump. Generally, they result in most drastic decrease in acid secretion, and this would be something like Prilosec. Note that if H. pylori infection is persistent, antibiotics must be given in addition to the acid-reducing medications, and you need to eradicate the bacteria. And then finally, the intestinal phase. This is the final phase of gastric acid secretion, which is responsible for only about 10% of the remaining acid secretion, after which it inhibits further acid secretions. This is triggered by the presence of partially digested proteins in fluid entering into the duodenum and triggering the enteroendocrine cells to release intestinal gastrin. The hormone has the same effect on gastrin that is produced by the stomach, which will stimulate hydrogen ion secretions from the parietal cells. The stimulatory effect of the intestinal phase is brief. As chyme enters into the duodenum, the declining pH and the presence of lipids will trigger what they call the enterogastric reflux. This will decrease vagal activity and acid secretions. The low pH in the duodenum also triggers the production of hormones by cells referred to as duodenal mucosa, including secretin and gastric inhibiting protein. Both hormones will release or reduce secretion abscess. And here you can see the intestinal phase breakdown there. Now, the main function of the stomach's motility enables it to perform three actions. One, receive food from the esophagus. Two, churn the incoming bolus into chyme. And three, is actually going to control the rate in which the chyme empties into the small intestines. In its resting state, the stomach has a volume of only about 50 mils, but it can expand to about 1,500 mils when filled with food and liquid. When food or liquid is swallowed, the gastroesophageal sphincter and the smooth muscle of the fundus and the body of the stomach will relax to allow the stomach to fill, known as a receptive relaxation. This is mediated by both the medulla as part of the swallowing reflex and the vagus nerve. Additionally, inherent ability of the smooth muscle to relax when stretched along the root allows the stomach to receive food and fluid without actually raising any internal pressure. This is important as an increase in gastric pressure can trigger vomiting, expelling the stomach contents through the mouth. The churning function after a meal, the smooth muscle layers of the stomach begin to produce waves of peristaltic contractions initiated and controlled by a group of specialized cells referred to as gastric pacemaker cells. And these pacemaker cells are much like the pacemaker cells that we saw at the cardiovascular system in that they are going to initiate these smooth muscle contractions. The peristalsis will propel the bolus to the pylorus, where small amounts of chyme are propelled through the pyloric sphincter into the duodenum. The remainder of the chyme is then pushed backward into the stomach, where the peristaltic waves will continue to churn and mix the chyme. I like to give an example of a cement mixer here. You release some of the chyme into the duodenum, and depending on the composition of the food, that chyme release could be pretty rapid, or it could take a very long time. If your chyme is carbohydrate-rich base, it's going to move through pretty quickly. If it's protein or lipid base, it's going to move through much slower. But any chyme that is not pushed through into the small intestines will get back into the stomach, and you have to continuously churn it, just like a cement mixer would keep churning so that the cement doesn't essentially harden. And you may have to add in some more secretions just to keep that going as the stomach is emptying. The pacemaker controls the rate of peristaltic waves, which remains pretty constant at about 3 per minute. The wave strength is subject to regulation by several factors, including stimulation from the vagus nerve, as well as the secretion of certain hormones. The enteroendocrine cells of the stomach produce hormone referred to as serotonin, and this will stimulate gastric motility. Another hormone that stimulates gastric motility is intestinal gastrin, which is produced by the duodenum. The emptying function is the final function of the gastric motility, and this is to control the movement of the chyme into the duodenum. Different materials pass through the pyloric sphincter at different rates. Again, going back to the composition of that chyme. Liquid move rapidly from the stomach to the duodenum with essentially no delay. Solids must be converted to a near liquid state before they are able to enter into the small intestines. Key factors that determine the rate of gastric emptying is the amount of and composition of the chyme in the duodenum. When sensory receptors in the walls of the duodenum detect stretch, low pH, and high lipid composition, and or high solute concentration in the chyme, that triggers a negative feedback loop and that delays the overall gastric emptying. The loop is then mediated by both the vagus nerve and the hormones secreted by the duodenum. This includes secretin, CCK, and gastric inhibitory peptide. Each hormone is also involved in the secretion from the stomach and other digestive organs. And here you can see the various stages of the gastric emptying there. Now, vomiting, normally the stomach empties the contents into the duodenum. Occasionally, the stomach contents move backward in an unpleasant process referred to as vomiting or emesis. This involves a complex motor response during which the smooth muscle of the stomach and the small intestine relaxes while the abdominal skeletal muscles and the diaphragm contract to increase intra-abdominal pressure. In addition, upper and lower esophageal sphincters relax, the soft palate closes off the nasopharynx, and the larynx elevates so that the epiglottis covers the glottis. So you don't want to aspirate vomit into your respiratory tract. Vomiting can be a response to various types of stimuli: emotional stress, overfilled stomach, presence of irritants such as alcohol and certain drugs, as well as viral and bacterial infections. The stimuli will activate sensory components of the vagus nerve, communicate via the medulla, and mediate motor responses of vomiting. Vomiting can be unpleasant, but sometimes beneficial. Many stomach irritants that stimulate vomiting could be harmful if they actually get absorbed into the bloodstream. And expelling them prevents this from actually happening. Antiemetics, these are drugs that treat vomiting, and they may act by blocking the neurotransmitter receptors in the medulla to prevent these neurons from actually initiating that process of vomiting. And this will be it for recording 2, where we will pick up with the small intestines.